Welcome to DM Neurology Made Easy. This is the 11th episode of Fine Neurophilia Quick Revision series. So, watch this video till the end to understand some core concepts of epilepsy with Epilepsy Part 2 video.
Now about febrile seizures. So patients definitely will be having family history. So any febrile seizure, if you ask, some family history will be there. And it will be not of an absence or focal seizures of preserved awareness. It will be actually a generalized tonic-clonic type. And seizure would occur only after the rising phase of temperature curve. It never occurs before the temperature curve. And that is the patient having fever, respiratory complaints, then later it develops. And it is actually a single brief isolated event and symmetric in appearance. We may have, because we are seeing lots of febrile seizure, we may think that febrile seizure is very common. And in a single patient itself, from 3 months, 6 months to 6 years is the usual time period we have in our mind. So the patient will be having recurrent febrile seizures, maybe once in 3 months and on. It's not like that. The usual thing is that febrile seizures usually is a single event. About 30 to 40% may have further seizures. That is just one more seizures. That is the usual studies which show. So it's very common condition, and it is most common seizures in child, and it's a very benign condition. And most febrile type, if some question has come, it is actually generalized tonic-clonic seizures. And they are typically symmetrical and last less than 15 minutes. If it's more than 15 minutes, we term it as a complex febrile seizure. And usually it should be only one seizure occur in a particular febrile illness. If more than one seizure occur in a particular febrile illness, then also we call it as a complex febrile seizure. And most affected children will not have recurrence of a febrile seizure in their lifetime. You should know all this, because once a patient comes to you, it's very important to classify it as a simple or a complex, because based on the typicality, we have to think of whether the patient is having any other undercurrent illness, whether we have to go for a lumbar puncture, whether we have to go for a prophylaxis with seizure medications, or febrile seizure, we don't usually go for MRI or EEG. So but in case of complex febrile seizure, definitely we have to think of otherwise. So complex febrile seizure have 3 criteria. So it should be more than 15 minutes. Focal features, if there, we should definitely be careful. And occurrence of more than one seizure in 24 hours or within the same febrile illness period. Then we have to think of a complex febrile seizure. So this is also very important, and this is because of a controversial thing in the clinical scenario, especially in case of pediatric neurology. This is a short question in the coming entrance. Now coming to the pathogenesis and pathophysiology, which is very confusing, and also these are kind of hypotheses. Since these are confusing, these parts you have to concentrate and read. So these are actually decisive questions. So these kind of questions, if you make mistakes, your ranks could come down. And if you have studied everything, you may not reach or get the top 100 or top 10. So these parts, it is very difficult to keep your concentration tight. So even if I have put the question, read Bradley part. This question I had taken, I think, from Harrison, so that you don't miss the Harrison part of pathogenesis or epileptogenesis. After reading Harrison, definitely go back to Bradley. So something called paroxysmal depolarization shift. As you know, there is hyperpolarization. There is a spontaneous hypersynchronous. That is, all the neurons are firing all together, suddenly causing this seizure activity. So why all neurons are causing this suddenly having this synchronous activity is due to something called as paroxysmal depolarization shift. So this occurs in a particular region of the brain. And after this occurs, this has to move or spread to cause a secondary generalization. So first thing is why this depolarization shift occurs. What is the mechanical phenomenon or the chemical, the ionic phenomenon behind this? So this is directly from Harrison. What do you think it is? The answer is that definitely calcium has to go in. So calcium, influx of calcium is one of the things which occur, and also there is influx of sodium which causes this. So hallmark. So what we see in an EEG, electroencephalograph, is called a spike. spike due to the intense firing. So a single neuron cannot produce a spike. A large amount of neurons within a particular area, say 5 centimeter square part of the brain, will produce only a spike. So this occurs because of the bursting activity in the individual neurons, which occurs all together. And it is a long lasting thing. It occurs because of the influx of calcium, and which causes this sodium channel to open. And there is further entry of sodium channel, and that causes what you call potentiates after potential mediated by GABA or potassium. So after this thing is made, this has to propagate. This has to move around, spreading on to other neurons. So this kind of electrical activity has to spread to other neurons. That is made by these four mechanisms. So this you can just read. I had, for your convenience, I had just put it in the slide. This you can read. So any problem in this? So if you see here in the third line, the NMDA receptors, etc., are acting here. So if some problems occurs here, then there is actually continuous seizures going on. That is why you have this NMDA receptor encephalitis. So NMDA receptor encephalitis, that is autoimmune encephalitis, even AMPA acts. So other receptors, LGL, etc., acts, causes continuous encephalitis and problems just because of this problems affecting in this receptors. So regarding EEG, next class I'll be telling you regarding a few things regarding seizures for you to read the basics. Just a simple question. So in the normal awake adults lying quietly with eyes closed, the background rhythm you see in EEG is definitely it's alpha rhythm. So no, it's not beta rhythm. Once you open the eyes, definitely there is beta rhythm. You have to remember one more thing. After being the eyes being closed, if you are not thinking of anything, or if you are just lying down with eyes closed, not thinking of anything, or not doing any mental arithmetic, then you get the alpha rhythm. But once you have something in your mind and you are like doing some calculations and all, slowly the beta rhythm will set in. And once you have, that is alertness. Slowly, if you, even if the eyes close, if you start alerting your mind, the beta rhythm will come in. So in that question, you should be careful. I didn't want to confuse you. That's why I didn't put the change the question as such. And if you, once you open the eyes, this beta rhythm. So it was, alpha rhythm was the first one identified by Hansbergen in 1929. And these rhythms are actually originating in the posterior occipital region. And mu rhythm is actually a variant. Mu rhythm is actually a variant. It's not a normal rhythm. So as we know, in this focal rhythms and generalized rhythm occurs. The absent seizures is actually a generalized rhythm. It's a continuous oscillatory rhythm. So where do you think this oscillatory rhythm originates from? Is it from the cortex, pons, amygdala, thalamus, medulla, etc.? What do you think? Basically from thalamus. Okay, so these are parts you have to learn. So this is, you can read from Harrison. So next things are actually few syndromes. So childhood onset syndromes I'll look into in the next class. So answer this question. In case of mesial temporal lobe epilepsy, what do you think is the right answer, which is not an MRI finding in it? Quickly answer, because one page has been dedicated and one table is there in Harrison regarding mesial temporal lobe epilepsy. Learn to draw the parts of hippocampus, cornu ammonis, etc. For your use. Yes, it's a pretty simple question. So I'll tell you something. So this is from Harrison table. So as you have seen here, it is actually enlarged because of there is temporal lobe atrophy. There is enlargement of temporal horn and not frontal horn. If you see here, this MRI, this is what MRI? Gray matter is white and white matter is dark. Gray matter is white and white matter is dark, and CSF is white. So this World War II, so water white in 2. This is a T2 weighted image, and this is a flare image. This is the flare image. Here, this is the flare image. Here also, you can see that the gray matter is white and the white matter is dark. So this is just the T2 with the CSF cutoff. And you can see here, there is dilatation of the temporal horn. And there is also something called, this is actually the region of hippocampus. So sorry, this is actually the region of hippocampus. And there is T2 hyperintensities in the region of hippocampus here. So these are the findings in case of, so atrophy is there, temporal lobe atrophy is there, temporal horn dilatation is there, T2 hyperintensities are there. So these are the findings. So very important question, read and answer. And we know about only single drug, that is carbamazepine, which is known to cause this thing. But other drugs can also cause these skin reactions. And this was also looked into with the help of HLA-1502 testing. So this I took just, I didn't cross check much. I just took from Harrison this sentence. Carbamazepine, phenytoin, lamotrigine, and oxcarbamazepine in Asian population can cause, with this HLA-B1502 antigen, can cause skin reactions. And so valproate definitely will not cause. So that is the thing. And studies, so this is just taken from Harrison, this purely from Harrison. And specific for carbamazepine induced hypersensitivity, especially in Japanese population, is HLA-3101. So these are probable MCQs. So don't make mistakes in this kind of questions. So the ratio of drug concentration in breast milk. So we may think that because we are giving in case of epilepsy, especially in case of female patients, left right, we are giving levetiracetam because we think it's safe. And after giving levetiracetam in a pregnant female, after she delivers, we continue giving this drug. And the lady comes to us and asks us whether it's safe, whether it will be secreted in her breast milk. We say that definitely it's safe and all. But the actual thing is that about levetiracetam is the one which will have the highest drug concentration in breast milk relative to the serum concentration. But now the question is whether we should continue when compared to other drugs. Actually, we can continue because it's still the safest drug. Even though its concentration is more, it is still the safest drug when compared to others. In what percentage of pregnant females with epilepsy does seizure frequency increase? So as we know, pregnancy and seizures, pregnancy and multiple sclerosis, pregnancy and migraine, all are very important. Pregnancy and stroke, everything are very important topic. But 30% will have their frequency increasing and 20% will have a decrease in frequency. And definitely fetal abnormalities will be more in 5 to 6% on those who are taking anti-epileptic medications. So what is the definition? So now we have seen status seizures. So when the seizures are prolonged beyond a certain period of time, we term it as status epilepticus. This is a very dangerous condition because we have to immediately act. So what is the definition of status epilepticus? What do you think it is? Seizures that persist for a sufficient length of time and becoming fixed and enduring condition. Seizures that persist for a sufficient period of time and there is no recovery between the attacks. It goes beyond more than 5 minutes of continuous seizure activity, or it is 2 or more discrete seizures between which there is no incomplete recovery of consciousness, or the answer is none of the above. So, but the latest definition is actually, it almost was similar to what the seizure classification was there. But the latest definition is not based on all these. The latest definition is based on something which is very much more complex. So it was given by ILA task force. You needn't by heart all this, but you should understand that it is based on the mechanism responsible for the initiation of seizure and why the seizure was not able to get control. That is why what caused the seizure termination could not occur. So it was based on 2 points, that is T1 and T2. By now you must have heard of this actually. What is T1 and T2? So just the definition is conceptual, and it is based on 2 time points, that is T1 and T2. So everybody, some people had messaged me what is the actual definition of status epilepticus. There is actually not proper definition of status epilepticus. In case of convulsive status epilepticus, both time points T1 is actually 5 minutes and T2 is 30 minutes, are based on animal experiments. So the actual definition right now is something like looking like this. So if it goes beyond, so T1 is the time when seizure is likely to be prolonged, leading to a continuous seizure activity. So seizure, as you know, it's usually subsides within 5 minutes. So after 5 minutes, that is the T1 period. And after 30 minutes, we call it as, it is not actually, after 5 minutes itself, we can call it as status epilepticus, or it can call it as early status epilepticus. And once it is beyond T2, it is the time when these seizures can cause severe neurological death, neuronal alteration, and functional deficits. So for all this, you have to learn. For tonic-clonic seizures, it is 5 and 30. For focal seizures, it's 10 and 60. For absence, it's 15, and it can go infinitely, or it is unknown. So this table you have to learn. It could be coming for your entrance, because this is the latest classification of status epilepticus, and it has not definite time period. But super refractory status, there is a time, that is 24 hours. But status epilepticus, they are now based on T1 and T2. So all those have asked me in questions, like ask queries in WhatsApp and Telegram for them. So what happens is that there is actually, when there is an imbalance between excitatory and inhibitory neurotransmission, there is chloride exit, and after that the seizure activity starts. So these are actually GABA channels. These GABA channels are there. So initially, when this GABA channels are activated, so this glutamate is the one which is excitatory, and GABA is the one which is inhibitory. But what happens is that once the seizure starts, because of this continuous seizure activity, these GABA channels become deranged. And once the GABA channel becomes deranged, and there is some internalization and some changes which occurs in this channel, even the GABA cannot act, and even the benzodiazepines which we give as the initial status epilepticus management, if we do not give in the initial period of this seizure status epilepticus, if we give after some time, these also won't act, because these GABA channels are actually deranged. You can see the deranged GABA channels. So that is the importance of treating status epilepticus and identifying it early. That is the need why they have put this T1 and T2. And status epilepticus is not just beyond 30 minutes or 1 hour. It's actually T1 and T2, and T1 and T2 times we have seen. And refractory status is seizures that persist after 30 minutes for generalized seizures, 60 minutes for focal seizures. And you should always think the use of 2 anti-epileptics. One is a benzodiazepine, and one could be a anti-epileptic drugs. These are the usual thing. And previously it was thought that there is no time period. Just some people had told there's 2 anti-epileptic drugs not getting control, one phenytoin and one benzodiazepine. But this is the usual thing followed. Status. And this is super refractory. This is a repeatedly asked questions regarding super refractory status. It's actually 24 hours. Because this is the one which has a specific time period, that is 24 hours. So classic lissencephaly. So there is a table in Harrison. You have to read it by heart. Lots of questions could come. So 3 questions I have made from it. Classic lissencephaly with the severe mental retardation. Only if you have read the table, you will be able to answer it. Those who have read the table will be able to answer it. As it's X-linked recessive. X-linked recessive. So just to see, I have marked the table important points, but you should mark yourself. Just see. So LGL1 gene is associated with which of the following syndromes? It is autosomal dominant partial epilepsy with. So these are all difficult things if you don't read. So just a single table will be able to give you answers or help you answer in the exam. if you study. So this is a high yield table. So don't mark it and read it. And the identification of SLC2A1A mutation, which encodes GLUT1 and causes GLUT1 deficiency syndrome. So in case of such a syndrome, what should we go for? Should we go for an epilepsy surgery? Should we go for sodium channel blockers, ketogenic diet, or should we go for cannabinoids? Immediately we have to start them on keto diet, because otherwise the seizures will aggravate and the patient will go for status and other neurological deficits. So most probable questions, which these are just from Harrison. So these are all probable questions. This was asked in the previous AIMS, I think, not this AIMS, previous Sri Chitra, I think. Yes, this was asked in Sri Chitra. SCN1A should generally be avoided. So this occurs in case of Dravet syndrome. So Dravet syndrome should generally be avoided while taking phenytoin or lamotrigine. That is because these are sodium channel blockers. And whereas patients with mutation in SCN2A or SCN8A, sodium channel subunits appears to rough. So if you check these mutations and if you find these kind two, and if in your question these two mutations are positive, we have to treat the patient with high dose phenytoin. But if you find this SCN1A, then we shouldn't treat, because it will aggravate the seizures. And ALDH7A1 gene, you have to treat with high dose pyridoxine. So know that. And autosomal dominant nocturnal frontal lobe epilepsy is due to mutation in which gene? Okay, so just I put these three questions from the table so that you will emphasize on the table. Now this is a video question. The EEG shows diffuse gene waves with chaotic background of irregular multifocal spikes and sharp waves. So with this chaotic background in the question itself, you must have come to an answer. But before that, I'll just show the video of the child. You can write in the chat what do you see? Yeah, these are actually salam attacks, but these are actually continuously, these are kind of occurring as a epileptic status. So that is the other thing. So I didn't put the polls, I guess. Question number 20. So what is the diagnosis in this case? See this video and try to answer. So first, I won't give you any diagnosis, any history of the patient. This is roughly around 60 years, 15 to 16 years female child. What is the semiology? Do you see? What semiology do you see? So mother is just now commenting that she was actually behaving as if she is from a different world. Her word output had decreased. She was using only single words, and her behavior has changed over past, I guess, 1 to 2 weeks. And so I'll launch poll. What do you think it is? So what you see in this patient is actually facio-brachial dystonic seizures. Facio-brachial. Face you can see, face movement you can make out, right? And patient also having ovarian teratoma. So this is actually a case of NMDA encephalitis. Patient was NMDA positive. She was given IVIG initially and later had to be given rituximab. It is not focal dystonia. It's actually dystonic seizure. It is an autoimmune. It is not pseudo seizure. She was initially treated by psychiatrists thinking that since she was having psychiatric manifestation initially, She was thought to be having not pseudo seizure, psychiatric problems, and was treated with antipsychotic medications. So all these autoimmune disorders, you have to have a high index of suspicion, especially in early stages. Even the EEG, I think I would have discussed. EEG will be having delta brushes. It is not normal delta brushes. It will be extreme delta brushes. That is delta range of slowing with brush-like activity in the top of it, which we will discuss in the next class. So this is actually autoimmune encephalitis. So this is the same patient after treatment. This is the video she sent to me after, I think, 2 months. She is actually a YouTuber making videos. So she is intellectually preserved even after having prolonged seizures. So this is the benefit you get of properly identifying autoimmune encephalitis and treating. Her ovarian trauma was also removed. So next class we will study about localization based on the aura, few things, EEG basics, different types of important seizure semiology, which will be asked in the next exams, drugs in seizures and treatment management, because last Neet treatment of status was asked. SUDAP is important, could be asked in the recent names. Epilepsy surgery, one or two questions we will see, and epilepsy syndromes. That is Lennox, Gastaut, West, Beck's, JME, etc. Few syndromes we'll learn. So I think this session was useful for you.